Science-based understanding as done by public health experts with
Good morning, madam. I'm not able to hear you.
Yeah, hi.
Hello, madam. How are you?
Good morning. Good morning.
Did you send your teams to our college for participating in quiz?
My people,
Which participants have come? No? PG students are supposed to be here, I guess. They are participating in quiz competition, no, madam, your students?
You're asking me, Sucharita?
Yes, madam. Uma madam only.
Oh, okay. Okay, yeah. No. Our students, all of them are busy.
Ayyo.
They are not participating in the quiz.
Ayyo. I thought only your students are coming. They are not coming. They are busy. At least Dr. Anant is coming, no?
Yeah, or some he's busy with some other aspect.
Okay. Oh, so no, only you came yesterday and you are participating in online today.
Yeah.
Thank you so much.
You.
I know everyone is busy, but yeah. Thank you so much, and thank you for your kind words yesterday.
Yeah, thank you so much for your super comparing, wonderful reception. Very good.
Because we love you so much, we want you to be taken care of to the best of our possible abilities, because we are running here and there with the technical program, and you're Dr. Shivaguru's beloved teacher. So we feel like it is an honor to take care of you. And we want teachers. So much. Yeah, we want teachers to be respected the most. So yeah, it is our privilege.
So great of you.
Yeah, we are waiting for 2 more speakers to join. The moment they join, we'll proceed, madam. I'll confirm with them. Give me a minute.
Okay. Thank you. Thank you, Sujata. Thank you.
Yes. Good morning to one and all who joined today for the symposium session. I request the speakers and the presenters who joined today to identify. I'm seeing in the participants list Mahi login. I'm believing it Dr. Muralidhar sir has joined.
Yeah, I'm here.
Sir, thank you so much, sir.
Yeah.
Yes, sir. And I'm so thankful for your
Recording in progress.
accepting.
Hello.
Good morning, namaste, sir. And Professor Dr. Uma Devi Madam has also joined, and we are just waiting for the third speaker, Dr. Swami sir, former Director of Public Health, Tamil Nadu. We are just giving 1 minute. Before that, I will introduce both of you. Professor Dr. Uma Devi Madam is Professor HOD, Department of Community Medicine, Sri Balaji Medical College and Research Institute, Chennai. Welcome, Madam. Welcome for today's symposium. And Dr. Muralidhar Verma, sir, your background is something unique for us. And from Manipal, we would like to listen, sir, because you are heading as chairperson of Hospital Infection Control Committee. You are working in HIV background as well. Can we listen to you? What is your professional background so far? And because I also have a fellowship in HIV, I just want to, before we start the symposium and wait for Dr. Swami sir to join, can we listen to your work so far, sir?
Yeah, anyway, in my talk, I'll just give a background about our hospital also. So
Yes,
I am working as an additional professor in Department of Infectious Disease now. Right. So we primarily look after the medical patients with interest of infections. Right. All the hospital infections like dengue, lepto, all the infections, HIV, all the HIV patients we manage. And apart from that, last 20 years, I've been working in infection prevention and control area. So right now, I'm heading the Department of Infection Control. So we look at the hospital-acquired infections. We make protocols for how to prevent infections. We actively do surveillance, right? All this, I plan it along with our infection control nurses. And we also actively participate in the transplant patients and oncology to treat their infections and also nephrology. So basically, we are looking at the management of all the infections. But I'm also part in prevention like you all, but primarily within the hospital level, not at the population level, how you all do. So primarily, I'm a clinician. So that's the odd thing. First time I'm talking in an community medicine conference. Thank you.
Wonderful, sir. That is also one of the reason we invited a mix of experts, clinicians, scientists, mathematical modeling experts from London. As you see, today's program has international experts joining us in panel discussions and lectures. We wanted to look at this conference theme is COVID-19 and universal health coverage. Though the Department of Community Medicine and Public Health, we are organizing this on the eve of World Health Day. We wanted all these interdisciplinary experts joining us and addressing this as a unique approach and universal approach and integrated approach. And when we approach clinicians and scientists from ICMR, yesterday we had the first lecture about community engagement, especially in the context of gaining the public trust in COVID-19 pandemic. Dr. Lokesh Shanmugam, a general medicine physician, a scientist in ICMR, he also brought a very new perspective, how a clinician entering into the public health arena is understanding it in gaining the perspective of public during the pandemic for vaccination. So now you are also at the opening remarks, you said, like, as a clinician, you are now part of this public health conference. So this is how we are trying to understand that synergistic contribution of multiple disciplines in addressing this. Now, though we wait for Dr. Kolandra Swami sir to join, the first lecture in this symposium is, though the symposium is titled COVID-19 and Building Resilient Health Systems, the first title is Challenges for Urban Health, Universal Health Coverage During COVID-19. And Professor Dr. Uma Devi Madam is going to deliver this talk, followed by yours. I don't want us to wait, and I want to be mindful of your commitments later. So we'll start off with Madam's session. Madam, would you like to deliver an oral lecture, or do you have a PowerPoint session to share, Madam?
I already shared it.
You want to share the screen? Yes.
No, I already shared that.
Yes, Madam. Yes, we can see the screen, Madam.
Okay. Yeah, am I audible for you?
Yes, Madam, audible, and the slide is also visible.
Okay. Thank you, sir. Yeah. Okay. Previous slide, please. Yeah. Can I start, Sucharita?
Yes, Madam. Yes.
I'm going to introduce a small introduction on universal health coverage and COVID-19 pandemic. Next, we started with the lesson we learned from the pandemic and also the barrier to the universal health coverage during the COVID-19 pandemic, and what are the ways to improve the access to universal health coverage amidst the pandemic. Yes. Yes. Universal health coverage means that all individuals and communities should receive the health services they need without suffering from any financial hardship. It includes the full spectrum of services, namely essential service, quality health service, from health promotion to prevention, the treatment, rehabilitation, and palliative care across the life course. Similarly, COVID-19 pandemic, we also know as a coronavirus pandemic. It's an ongoing global pandemic of coronavirus disease 2019. It is caused by severe acute respiratory syndrome coronavirus 2. This novel virus was first identified from an outbreak in Chinese city of Wuhan in December 2019. An attempt to contain it was failed and allowing it to spread across the world. This WHO declared public emergency of international concern on 30th January 2020 and pandemic on 11th March of 2020. As of latest data, 27 March 2022, the pandemic had caused more than more than 480 million cases and 6.12 million deaths, making it one of the deadliest history. Now we'll go on to the lessons learned from the pandemic. All countries, they need to improve their organization and functioning of the health system for pandemic preparedness and beyond. Before the pandemic, most national health system has been able to function adequately with only basic preparedness measures. But when the pandemic took us by storm, it revealed the fact that the national health system, it is very weak across the globe. Thus, what is the lesson we are taking from this is we must prepare in such a way that we can handle any infectious pandemic or any other uncertain disaster. Another lesson, all countries, they need to invest in addressing the foundation health system gaps and essential public health function for the emergency management. Actually, foundation of the health system is stake in many countries. The pandemic taught us that the health system that is already in place, they are not enough to handle the emergency situation, as there was increased mortality and morbidity. We would have reduced this mortality and morbidity if availability of the beds and the basic treatments were adequate at the health centers. And also it is highlighted the fact that our PHC orientation system was weak, health literacy was low, and there is a lack of health emergency management system, and also there is a lack of education, basic training, and professional development in emergency preparedness. The maintaining the essential health services must be considered as high priority as ensuring the emergency response. In order to respond to the emergency situation, the essential health services are very, very important. Though the pandemic hit us very hard, essential health services like antenatal, postnatal care of the TB patient, HIV patients were provided in the PSC. These services were adapted and maintained, which is a major breakthrough in our national health system. Equal importance must be given to the essential services as well as emergency preparedness. Another lesson we learned from the pandemic, in order to tackle the pandemic, good governance, a good leadership, and the public trust, they are very, very essential. The government in which the population trusted the leadership, acknowledged the threat very early, and made wise healthcare decisions, thereby coordinated the preparedness activities. These type of government, they can do a better job in preventing the community transmission. They use the successful measures like pooling resources in advance, involving the private sectors, and made use of the technology and proper surveillance system. And also, another lesson we learned is health policies are needed to be revised and priority should be given for the health research, laws to be enacted to protect healthcare personnel, especially during the time of pandemic, which requires amendments in the Epidemic Act 1897 and Disaster Management Act 2005. Now we'll go on to the barrier to the universal health coverage during the pandemic. Regarding the reproductive and child health problem, it is the major thing is we are able to run the RCH services, but there was a shortage of health professionals in delivering these services because many of them were diverted to the COVID activities. Regarding malnutrition, because of the pandemic, many people lost their job. The poorer become more poorest, and that leads to the problem of malnutrition. There are also issues of gender equality. The female, when compared to the male, they had additional work at home, taking care of the family, in addition to the heavy workload at the health center. And finally, the poor availability of the trained human resources in health act as a barrier to during the pandemic. And in addition to this, inadequate research to achieve healthcare for all, and our healthcare delivery system is mostly commercialized, fragmented, and unregulated. And there is an inequalities in access to the healthcare and also imbalance in resource allocation and high out-of-pocket health expenditure. And also there is a lack of intersectoral coordination. This can be overcome by involving the community service workers at the grassroots level with the basic training in emergency preparedness and responses. This pandemic would not have been such a huge burden for our health sector if we involve the community service workers in the basic training. There is always political pull and push of different forces and interest. Rising age, other factors like rising aging population and other social determinants of the health, such as poverty, illiteracy, alcoholism, etc., they act as a barrier to the universal health coverage during the pandemic. So, what are the ways to improve the access to the universal health coverage amidst the pandemic? Strengthen the health security system within broader UHC reforms. The UHC reforms should ensure coverage of full continuum of health services, including health promotion, prevention, and treatment. Very particularly, the surveillance and emergency preparedness should be a part and parcel of the primary healthcare system. Prioritize closing primary health gaps for universal health coverage. The priority must be given for achieving a greater population coverage with a basic package of services focused on the primary care rather than building an additional tertiary hospital. COVID-19 provides a political window of opportunity to launch UHC reforms. The leaders should act decisively in reforming their health system and also extending the effective health coverage to all the people. Increase pooled public financing for health to at least 2% of GDP and replace private out-of-pocket spending. Increasing revenue for health from innovative public sources, including taxes on commodities that are harmful to health, notably tobacco, alcohol, and sugar. Improve the quality of care through sustained health system strengthening. Increasing the health worker training in pandemic preparedness and protection. This can be achieved by increasing the health workers training in the pandemic preparedness and protection. Invested in strengthening of human resources for health, especially community health workers. This can be made use by availability of the motivated and training and well-managed health workers. At the same time, the substantial investment in human resources to recruit more health workers and improve their pay, conditions, and supervisions. Be willing to pay more and invest better for equity. We must address the specific health needs of the vulnerable people, namely the women, children, adolescents, elderly population, people living with a disability, etc. We must pay more attention and invest better for them. Engage the private sectors in tackling the COVID-19 and UHC reforms. And next, strengthening the governance and accountability systems. And finally, we have to engage beyond health to strengthen the critical driver of the UHC system. Critical drivers, we have to concentrate on the risk factors for both the non-communicable and communicable diseases and try to take it out. Next year. So that brings us to the end of the presentation. So far we saw about the lessons learned from the pandemic, followed by barriers to attain the UHC during the pandemic and the ways in which we can improve the access to the UHC. Though many steps are taken by the government, including stakeholders at various levels, we can achieve universal health coverage if and only if we at the individual level participate effectively through community participation, so that we can overcome all the barriers and attain universal health coverage. Thank you.
Thank you, madam. That was a wonderful session addressing the challenges for universal health coverage during COVID-19. We would like to welcome Dr. Kodandaswamy sir, the former Director of Public Health, Chennai, Tamil Nadu. Welcome you, sir. We are unable to listen to you. We request you to unmute.
Yes, madam. Thank you, madam. Thank you. Thank you.
Namaste, sir. Thank you for accepting graciously our invitation and being part of this international hybrid conference. Because earlier we waited for you, but we apologize. We started the session without you because we wanted to be on time. We apologize for that.
No problem. No problem. I told Vinod to start, madam.
Yes, sir. The symposium was titled COVID-19 and Universal Health Coverage, Building Resilient Health Systems. And the first session was delivered by Professor Uma Devi Madam, Professor HOD, Department of Community Medicine, Sri Balaji Medical College, Chennai. Madam talked about challenges of universal health coverage during COVID-19. I saw you joined during her session.
Yeah.
Now, second session is Reimagining Health Systems by Dr. Muralidhar Verma. Sir is Chairman, Hospital Infection Control Committee, Associate Professor, Department Infectious Diseases, KMC Manipal, Mahi. We welcome Dr. Muralidhar Verma to deliver his session. Sir?
Thank you. I'll just share my
Screen.
slides. Yeah.
Yes, sir.
Can you see my slides?
Yes, sir.
Yeah. First of all, thank you very much for inviting me. Dr. Shri has been regularly communicating. Looks like she has a wonderful planning always. So she has been communicating almost like 2 months now. That is wonderful. I would have not done that far ahead. Yeah. That anyhow. Thank you for the invite. As I told, I'm a clinician. Probably one of the few talks I give for the public health people. Right. So I will stick to my strengths and what we have done here and what is our vision. So I will stick to it. So I will look primarily looking at the hospital-based issues rather than the community and see what we can plan in the future. So just to highlight what I'm going to tell, we'll just share a little bit of our experience since we have only 10 minutes, 12 minutes to talk. What are the lessons we have learned through the pandemic and what is the way forward? So let me first introduce our Manipal. Manipal, we are in Udupi district in Karnataka state. We are the coastal district. Okay, it's Manipal is primarily a university township. We have students, teachers, and few employees. That's the primary, and few small industries. Udupi, is a temple town. So this is our university, which is world famous now. And I work in a hospital owned by university. This is our Manipal hospital, which we call Kasturba Hospital Manipal. It's about 2,032 beds. It's a huge hospital. We've just finished 60 years of our hospital. So that is the background we come. So we will just tell you how we went through the COVID and see some of the challenges, how I faced during this. So when you look at the Udupi district, we are the biggest hospital and everybody comes to us. And the neighboring districts also probably we are the biggest hospital. So that has been going on since many decades and that put a lot of pressure on us. But a lot of good things happened because we had some planning in advance. The highest level of political and administrative commitment was there and all departments, NGOs, everybody came together, right? And there was a very proactive identification and tracking and quarantine systems, especially when it initially started. And we have a lot of people who go to Gulf and come back. So that is where our first system of barrier system started. Then what has happened is university and hospital took a wonderful decision, right? So you know that our hospital is big. We cater a lot of patients. And we have a lot of departments which cater very sick patients. We have oncology, nephrology, we have transplant units, we have huge 200-bedded ICUs. So one of the big challenges we have is we are probably the only hospital nearby who can handle very sick patients. Bringing the COVID patients to our hospital would have created a lot of trouble because the normal patients will suffer. So that was the biggest challenge. So what we have decided is we have a sister hospital in the Udupi, which is about 200 bedded. So what was decided is all mild and probably moderate patients will be admitted there. And asymptomatic patients in the district health facilities where they have sort of good facilities there, and COVID care centers. We have converted some of our hostels into COVID care centers, and we managed. So I have managed the protocols for how to go in, come out, dresses, PPE, etc. So that was the uniqueness because ours was a university town. So this is the hospital, our sister hospital, where we have put everything. First thing, the best part university did is, before Ayushman came, the entire cost of all the COVID patients positive was borne by university. That was really good thing that put all the admins, district health authorities to align with our university, because university said they'll make it free of cost. Of course, after a couple of months, government launched Ayushman Bharat, and then it finally did it. So that actually made our hospital in a unique position throughout the state. Where it impacted us is this public-private partnership, which I feel is a very, very important thing going forward for tackling a lot of problems, let it be infections or non-infectious problems. So having this partnership, so that was Awakening, and university did a wonderful work. Then what we have done is, as the first wave came, then second wave came, so we made a system that all very sick patients, we have created a completely different block within our hospital. Want of time, I have not put too many stats here. So all non-sick, mild to moderate, we managed in the government hospitals with our doctors, and also in the KMFI hospital. So whoever we had were very sick. Either they are a minimum on 60% venturi to rebreathing mask or a complete ventilator. So whatever patients we have admitted, they were very sick. So we have dedicated a team for it within our group of doctors and postgraduates, and we manage that. So our mortality rates were not that high compared to the Indian standards, whatever were published. So this system really helped. This has awakened us. The primary reason we could do all this is we had a lot of experience when we managed H1N1 pandemic. Those who remember in 2010. So I was heading the whole task force of our hospital, and we learned a lot of lessons. So that's the reason why infection control prevention was such an important thing in our hospital. So we've learned a lot of lessons, and we modified some of the protocols in hospital up ahead before the national guidelines came. So this is all how an experience helps us. So experience sharing was one of the biggest success, I would say, for the COVID, because of the online lectures, etc. So this is a typical flow how we follow in our infection control, right? The mantra of preventing infection. This is from CDC, NIOSH. So when you have, this can be applicable to a facility, or it can be applicable to the public health also, right? When you have a problem, you can, the first step is to eliminate the whole problem, right? Eliminate the problem. That's the first thing we did. So how do we prevent COVID coming to our hospital? So we created a sister hospital and diverted all the COVID patients, at least initially, right? That was a big move based on this theme. Then substitution, right now there is no real strategy for substitution of COVID, even though some were tried on experimental basis like UK and all. Then engineering controls. This was what creating COVID wards, isolating people. Then administrative controls are something like creating social distancing, creating barriers. I'll show some of our experiences how I managed. Then of course PPE. The important thing to remember from this is, unfortunately, we end up giving too much importance to the tip of the pyramid. Remember, this is an inverted pyramid. The whole focus should be here if you want to eliminate or prevent any infections. So that should be the whole focus. So sometimes we feel government is more stuck on here rather than here. Okay, that's where your team becomes very important, the preventive medicine and also the public health departments. The other big challenge is, which I was not surprised about, is the human behavior. Okay, any disease prevention is ultimately about making the science correct, and then it boils down to human behavioral change. You might have a best scientific model, but if you cannot change the human behavior, you will not be successful. And COVID taught us perfectly that. So our experience in the past 20 years really helped us in assessing all this. Like you always see people going on the road trying to cross in an opposite road, creating accidents. These are all not that they don't know about the rules. They are educated, they know the rules, but despite that they break rules because that is convenient to them. So when you make policies, either in the hospital or in the community, the convenience should not be given. Okay, it means drawing red lines. So that starts with education, then starting training and risk assess. You can't apply same rule across the hospital or community. So you risk assess. Say for example, in our hospital, I put a completely different rules in cancer block, ICUs, because I know they are the sickest place. Then creating barriers. Slowly what happened is people got used to it. It's like I remember still our mask adherence rates were so fluctuating during the COVID time, and there was a lot of hindrance when the first wave came down. So you have to make an habit and make it as a new normal. Just to prove a point, so we have started a system in our hospital where I knew that when you don't keep barriers, people will break rules. So first thing I created with the administration is we created a buffer zones. This is just a snapshot of one of the COVID wards. You can see here, this is where we are all standing. There's an yellow line here at the bottom, which is the non-infected zone. So these people require only a mask and probably a gown. That's it. You can see here, there is a nurse and the housekeeper.